All right, future doctors, welcome to a super high-yield explainer on healthcare-associated infection surveillance. If you're deep in board prep or getting ready for your clinicals, you are in exactly the right place.
So everything we're about to cover is grounded in the work of a leading expert in infection control, Professor Rehab El-Sokari. We're basically distilling her teachings into the essential framework you absolutely need to know.
Okay, first things first. You gotta get it out of your head that surveillance is a one-time thing. It's not. It is a dynamic, continuous cycle. You see, it starts with a plan. You collect and analyze the data, and then, this is the crucial part, it all feeds back into making things better for patients. It's a loop that never stops. Let's break it down. Here's our game plan for today. We're gonna cover the big picture framework, then dive into planning, collection, and analysis. And definitely stick around to the end because we're going to wrap up with a rapid-fire review that's perfect for your exams. Let's jump in. Okay, so let's start with the big picture here. Before we get lost in the weeds, we have to ask the most fundamental question. Why do we even do this? What is the whole point of surveillance? I think this quote just says it all, doesn't it? The point isn't to create a pretty report that sits on a shelf. Not at all. The real goal is to use this information to actively stop infections from happening. The data? Well, that's just the tool we use to get the job done. Now we're moving on to what I think is the most critical step of all, planning. You know, if we get this part right, everything else just falls into place. And as you'll see, it all kicks off with nailing down a solid definition. Just think about it for a second. How can two different hospitals, heck, how can two different units in the same hospital compare their infection rates if they're not even counting cases the same way? You can't. You could have one unit looking like heroes and another looking like they're failing, all because their definitions just didn't line up. This chart breaks it down perfectly. You've got 3 steps. You assess your population, you select your outcome, and then the third one, this is the key, you use an established standardized case definition. That last part, well, it's completely non-negotiable if you want data you can actually trust. And this right here is a huge distinction, especially for your exams. A surveillance definition is not the same as a clinical definition. A clinical definition, that helps you treat the one patient right in front of you. But a surveillance definition, that's about counting and comparing cases across a whole population. They have to be uniform. They have to be standardized. You know, getting that definition wrong just poisons everything that comes after. You'll end up missing cases, which means you're underestimating the problem. You might misdiagnose the type of infection, so you're chasing the wrong solution. And you'll create so much bias that any comparison between facilities becomes totally meaningless. Okay, so we've got our standardized definition locked and loaded. We know exactly what we're looking for. So what's next? Well, now we have to actually go out and gather the data. Let's talk about collection. Pay really close attention here. This is a classic exam topic. You have to decide what you're measuring. Are you interested in the rate of new infections popping up over, say, a month? That's incidence. Or do you want a snapshot of all the current infections on one specific day? That's prevalence. And taking a look at the math really makes it click. For incidence, you see the numerator is only the new cases over a period of time. But for prevalence, it's all the cases at one single point in time. It all just comes back to the question you're trying to answer. Next up, you've got a strategic choice to make. Do you go with active surveillance, where you're literally hunting for cases? You'll get much better data, but it costs a lot of time and money. Or do you choose passive surveillance, where you're relying on existing reports? It's way easier, but you're pretty much guaranteed to miss some cases. The right call really just depends on your goals and your resources. So, you've planned your study, you've collected your data, now the fun really begins. The next step is turning all those raw numbers into something that's actually useful. Welcome to analysis. But wait, before you calculate a single rate or make a single chart, you have to stop and ask yourself this critical question. Because look, data quality is everything. If your data doesn't reflect what's actually happening, your analysis will be useless at best and dangerously misleading at worst. So what messes up our data? I like to call these the 4 horsemen of bad data. You've got missing or incomplete records, people not sticking to those standard definitions, sketchy lab support, and probably the most common one, having untrained people collect the data in the first place. Just one of these can totally sink your entire effort. This is so important. You can't just compare the raw infection rate from a surgical ICU to an outpatient clinic and call it a day. It's not a fair fight. The patient risks are worlds apart. That's why we use risk stratification. It lets us group similar patients together so we can finally compare apples to apples.
All right, we have covered a ton of ground, so let's do a quick recap of the most important high-yield points from all this. This is the stuff you want to lock in.
First off, always remember, surveillance is an active, ongoing cycle of improvement. You plan, you collect, you analyze, you use that info to make changes, and then you start the whole loop all over again.
Second, and seriously, if you forget everything else, remember this. Your data is only as good as your case definition. It has to be standardized, it has to be clear, and it has to be used consistently. It's the bedrock of everything. Third, there is no single best method. The method you choose, whether it's incidence versus prevalence or active versus passive, it has to be a perfect match for the question you are trying to answer. And finally, be a data skeptic. Always approach your data with a critical eye. Validate it, check for completeness, and understand its limits before you even think about drawing any conclusions. And that brings us to our final thought. As you go on in your careers, remember, this whole process isn't just some academic exercise. It's about protecting patients. It's a powerful tool, and that responsibility is going to be in your hands very soon.